We'll start with the oral presentations, and our first presentation is entitled "The Predicts Panel of Biomarkers is Associated with a 28-fold Increased Risk for the Presence and Progression of Atherosclerosis in Women with SLE." This will be presented by Dr. Maureen McMahon on behalf of her colleagues from UCLA, David Gaffney School of Medicine, Harbor UCLA Medical Center, and Cedars-Sinai Medical Center.
In my ear? Oh, sure. Coming? Okay. That's it. First, I'd like to thank the organizers for inviting us here to present our work today. So I'm sure many of you here are familiar with the increased risk of atherosclerosis in lupus patients. Overall, even after controlling for traditional cardiac risk factors like hyperlipidemia, there's still an 8 to 10-fold increased risk for stroke and heart attack in lupus patients. When we looked at our own UCLA cohort, we found that 64% of those patients who had documented atherosclerosis had normal standard lipid profiles, highlighting the idea that traditional cardiac biomarkers might not be adequate for predicting risk in our lupus patients. When we discussed this with our cardiology colleagues at UCLA, they told us about a small cohort of patients from the general population who had documented coronary artery disease but no discernible cardiac risk factors. But in those patients, they found that they had abnormal functioning HDL, or pro-inflammatory HDL. This led us to question whether pro-inflammatory HDL and other non-traditional biomarkers might be able to predict atherosclerosis in lupus patients. So to understand how pro-inflammatory HDL and other biomarkers might increase the risk of atherosclerosis, we'll discuss first the pathogenesis of the atherosclerotic plaque. Reactive oxygen species are produced by the endothelial cell wall. Production of reactive oxygen species can be stimulated by leptin and homocysteine. When LDL enters into the subendothelial space, it interacts with these reactive oxygen species to produce oxidized LDL. And it's oxidized LDL that goes on to have many inflammatory functions. It can upregulate chemokines, leading to the influx of monocytes and ultimately formation of macrophages in the endothelial wall. These macrophages then go on to take up oxidized LDL to form the foam cells around which plaques are built. In addition, oxidized LDL can stimulate macrophages to elaborate cytokines such as TNF-alpha and IL-1, which can lead to endothelial cell activation and the upregulation of adhesion moles, which further drives the inflammatory process. Now, typically, HDL would to counter-influence this process in several ways. It would decrease the amount of oxidized LDL present in foam cells, and in addition, HDL can normally block the oxidation of LDL and block the activation of endothelial cells. However, pro-inflammatory HDL is not able to perform any of these protective functions, and in fact can increase the amount of oxidized LDL present, thereby causing increased inflammation. We've previously presented data that shows that pro-inflammatory HDL is highly associated with the presence of plaque on a cross-sectional carotid ultrasound study. So this led us to wonder whether the presence of pro-inflammatory HDL and any other biomarkers might be associated with future progression of plaque. So we have a longitudinal cohort study comprised of 210 women with lupus and 100 healthy controls who were age and gender matched at baseline. Our only exclusion criteria was the use of any statins within 6 months of study entry, because statins have been shown to improve HDL function, although not to normal levels. However, statins were patients who started on statins.
Can I have some assistance, please, because we don't have the right slides being shown? Like these are slides? No.
I have the right ones here.
We apologize. We're
there we go. Okay, shall I continue from where I was?
Yeah, I think it's better, right?
Yeah, okay. Okay, so the only exclusion criteria that we had was the use of statins within 6 months of entry, although patients who started on statins after the initiation of the baseline exam were allowed to continue in the study. Every subject had a carotid ultrasound performed at baseline and then again at a mean of 29.6 months after the initial study. All patients underwent cardiac risk factor and medication assessments at both baseline and follow-up. In addition, we looked at a number of biomarkers, most of which we will not discuss here, but which I've listed for you to take a look at. Overall, we found that plaque progression occurred in 22% of lupus patients and 16% of controls. Overall, we found that increased plaques occurred in almost 10% of lupus patients compared to 7% of controls. We saw plaque regression in 5 of the controls and 1 of the lupus patients. So overall, at the longitudinal follow-up ultrasound study, 29% of lupus subjects had some evidence of plaque. When we looked at the traditional cardiac risk factors that were associated with plaque, we found that a history at baseline of diabetes, increased age, higher body mass index, higher levels of leptin, and higher tweak were all associated with the presence of plaque at the longitudinal ultrasound. In addition, looking at lupus and treatment factors, we found that higher disease duration at baseline was also associated with plaque at the longitudinal ultrasound. However, we found no association with baseline disease activity or with any medications, including lifetime prednisone, hydroxychloroquine, or the initiations of statins after the baseline visit. Overall, we also found that pro-inflammatory HDL was associated with the presence of plaque at the follow-up ultrasound. 81% of lupus patients who had plaque at follow-up had evidence of pro-inflammatory HDL at the baseline visit, compared to 40% of those without. In addition, we also found that pro-inflammatory HDL was associated with plaque in the control group. So when we took all of our potential biomarkers that were positive on univariate analysis and also included potential confounding factors, we found that pro-inflammatory HDL, higher age greater than 48 years, high leptin, high soluble tweak, and diabetes were all associated with an increased odds for having plaque at the longitudinal follow-up exam. So you may wonder how we arrived at some of our cut points that we used in our logistic regression model. Well, in addition to univariate and multivariate analysis, we also used a Selford predictive modeling software, which not only helps to determine which variables are associated with our outcome of interest, but also what the most predictive cut points are. And that's how we arrived at those listed here. One interesting thing we noted is that all of these markers have been associated at times with high oxidative stress. Overall, we named these molecules the predicts variables. So overall, when we looked at individual predictors like pro-inflammatory HDL, we found, for instance, that pro-inflammatory HDL has a very good negative predictive value at 89% for the presence of longitudinal plaque. However, the positive predictive value was very low at 46%. Similarly, each of our variables of interest had strengths and weaknesses as overall predictive variables. For instance, diabetes and a combination of traditional cardiac risk factors were very specific for the presence of longitudinal plaque, but their sensitivity was quite low. However, we then looked at a combination of our predicts variables, and we defined high predicts as having 3 or more of our predictors or the presence of diabetes plus 1 of our predictors. And we found the overall predictive capacity was improved compared to any individual variable, with a negative predictive value of 94%, a positive predictive value of 64%, specificity of 89%, and sensitivity of 79%. Overall, patients who had high predicts had a significantly higher chance of having not only any plaque at the follow-up exam, but also any new plaque progression, an increased number of new plaques per year, a higher IMT at follow-up, and a higher change of IMT per year. Controls with a high predicts at baseline also had significantly higher chance of plaque on follow-up exam and a significantly higher IMT at follow-up. We did not have a large number of coronary events that occurred during the course of our study, but among the 5 patients who had a coronary artery disease event at follow-up, all 5 had high predicts at baseline. We did not see a significant association with stroke. Overall, when we plugged our high predicts variable back into our logistic regression model, we found that patients who had high predict at baseline had a 28-fold increased odds for the presence of plaque at follow-up exam. African American race and dyslipidemia were also associated with increased odds for plaque. Looking at high IMT in the highest quartile at follow-up, patients with high predicts had an 8-fold increased odds for having an IMT in the highest quartile, and patients with hypertension also had significantly increased odds. So to summarize, in conclusion, pro-inflammatory HDL are significantly associated with plaque on baseline cross-sectional and longitudinal carotid ultrasounds in lupus patients. However, although the negative predictive value for plaque is high, the positive predictive value is fairly low. So we've been combining pro-inflammatory HDL with other markers of oxidative stress, including age, high leptin, high tweak, and high homocysteine, as a combined predicts variable that has an overall predictive profile that's improved compared to any individual biomarker. A high predict score confers 28-fold increased odds for the presence of any current progressive or acquired carotid plaque in lupus subjects, and also significantly associated with higher rates of plaque and IMT progression. Thank you.
Congratulations for your beautiful work, and I have a question for you. So when you defined your panel of biomarkers, why you didn't choose, like, for example, interferon type 1, since it's very well established in the human and mouse literature that it's very linked to atherosclerosis pathogenesis?
The phenotype of what, I'm sorry?
Interferon.
Interferon. You know, we actually looked at interferon scores in our cohort, and we did not find any association in our cohort with plaque. So I'm not sure if we had a larger, more representative cohort of the entire lupus population, perhaps we'd see that, but we didn't in our group.
Thank you.
We have time for one more quick question and quick answer.
Stockholm. So thank you very much. This was really interesting, and I was just wondering, and I apologize if I missed it in the beginning, if you may have said it, but because you looked at plaque, and that would be, but plaques can be stable or unstable, and the unstable plaques correlate much better to events. So have you been able to look at prediction of events?
I can't hear you quite very well, but did you ask if we looked at plaque stability?
Yeah, or rather, if you have looked at events, cardiovascular events.
Events?
If you can predict those with the predicts rule.
Right, yeah. So we don't have a large number of events, but what the events that we did have were associated with the predicts variables. We did look at some measures of plaque stability just with plaque morphology, and there's our cardiology colleagues sort of advised us that there's some controversy with that, so we haven't really been talking about that much. But the measures that we did look at, it looked like more unstable plaque was also more highly associated with predicts.
Great.
Thank you.
Thank you.